Yeah, yeah.
Yeah. So the recording, is it on or
Yeah, it's on. It's on.
okay?
I mean, when I joined it,
Oh,
said it's on.
okay. So, being the EC coordinator of Women and Child Mental Health Subcommittee of, should I say Indian Psychiatric Society West Zone or
Psychiatry
Better say
Society.
Psychiatric Society
a
West Zone.
Psychiatric Society Western Zonal Branch? I welcome all of you to the second webinar. The first one was on autism. Today, the second webinar is on addiction in women. We are having excellent speakers, Dr. Narsima from Nimhans and Dr. Preeti from AIMS Delhi. I would welcome our chairperson of the subcommittee, Ritimra ma'am, to welcome our president sir and the speakers and all the committee members.
Hello all, good evening. And this is our second webinar on the series of Women and Child Mental Health Subcommittee. And with our very enthused team, we have been able to actually plan 2, 3 more webinars, and every month we'll be having the webinar. Sir, Dr. Sudhir Bhave, our president of IPL West Zone, is here. We welcome you, sir.
Thank you.
And thank you for encouraging us. And we definitely keep on giving better and better programs every month. Thank you for all the support that you are extending to us. And
My pleasure.
of course, your whole team is with us. We know Dr. Fai and others. So thank you. And if you would like to say a few words, sir.
No, not really. In fact,
No, sir, we
think
need your blessings.
I think blessing is a very big word. My good wishes. I'll just say that this subcommittee has been very active, and perhaps I might say that the maximum amount of communication traffic, I mean, or productive one, is perhaps on this subcommittee is a WhatsApp group, and all very fruitful communication. And I'm sure, the topic for today, addiction, and I was just telling Kathy that this is a topic that is often not discussed. I mean, when we talk of addiction, the typical stereotype visual image is that of a male addict, and
Yeah.
hardly ever thinks of a female addict in the Indian context. So I'm very glad that this topic has been chosen, and we have two speakers from some of the best institutions in the country who are working in the field of de-addiction. So I'm very sure that today's seminar is going to be very helpful for anyone who attends it. So thanks, Rakambara ma'am, for thinking of this idea and uh, gathering such good speakers. So my good wishes for the seminar. So I hand it over to you, Dr. Mehta.
Thank you. Thank you very much, sir, for your wishes and your presence. And I'm sure this topic, as sir said, it's very different. And as women, though actually we know sometimes, but we have not really deliberated on this topic as a subject as such. And we have these experts who have been working on this field for quite some time. And they have tried to make it more interesting by actually taking a quiz also. So probably you all look forward to giving some answers, and so that's how to make it more interesting. We have planned the program in a very good manner. So over to Khyati, and as moderator, she will take us forward. Thank you.
Yeah, so firstly, I would like to welcome our chairperson, Dr. Shilpa Adarkar ma'am, who is
Thank you.
a technical team. Can we have the slide, please? Uh, I, technical person, is it there?
Kathy, it's okay. We can go ahead.
Yeah, okay. So Shilpa ma'am is a renowned psychiatrist with extensive experience and expertise in addiction medicine and yoga therapy. She has got 26 years of experience as an additional professor in the Department of Psychiatry and Drug Addiction Center of Excellence State GSMC and KEMH. She is the Nodal Officer of Regional Resource and Coordination Center, DTC scheme, Ministry of Health and Family Welfare, Government of India. She has been in many leadership roles, like she is the ex-president of Bombay Psychiatric Society, uh, 2019 to 20. She is the chairperson of Addiction Medicine Specialty Section of IPS, and she is the advisor of PG Psychiatric Education Committee, IPS Western Zonal Branch. She is a member of Addiction Psychiatry Society of India, member of National Scientific Committee for Addiction Prevention. She is the member of Rotary Action Group for Addiction Prevention. Besides her training as in MD and DPM, she has taken a certificate course in yogic culture and diploma in yoga therapy, Kaivalya Dham, Mumbai. Her areas of interest are addiction medicine and yoga therapy. So over to you, Shilpa ma'am.
Thank you, Kathy. I meant that we can skip the introduction and we can go ahead so that we can start. Anyway, thanks
No,
a
we
lot.
need, yeah.
And before we begin, I'm sure we are all waiting to hear from Dr. Narasimha and Dr. Preeti. We at the Addiction Center, and I'm here since many years, almost 30 years of the Addiction Center now as a resident and then as faculty. Initially, women would come only probably for tobacco. Later on, we started seeing the change and there would be alcohol use disorder as well. But recently and over last few years, what we have seen is that, and the age of women is also going down. We are seeing more and more young girls, and the substances that are used are not only tobacco and alcohol, but also cannabis, opioid, some of the stimulants like mephedrone as well as amphetamine type of stimulants. So I'm really, and recently, just last year, a few months ago, we had a Bombay Psychiatric Society clinical meeting from our unit, and we presented the same topic, substance use in women. So I'm very glad that it has been taken by the subcommittee of West Zone, and I'm very happy to be here. Thank you, Dr. Ritambara ma'am, Dr. Bhave, Dr. Khyati, for inviting me here. And should I start with Dr. Narasimha's introduction? Khyati?
Yes, ma'am. Yes.
Okay, so Dr. V.L. Narasimha is MD, PDF, and DM in addiction psychiatry, and also an ISAM certification he has, working as an assistant professor at Center of Addiction Medicine, NIMHANS, has 55 publications, is a Google total Google Scholar citations and H-index there are 13 and 770. Many funded projects. He's got awards like Best Researcher Award, ISAM, NIDA Fellowship, DST Travel Grant, World Psychiatric Association Travel Grant, Fellowship of Dr. Ramachandra Murthy Foundation, and INE BRI Scholarship 2021. So I don't think there can be anybody better than him to speak on this topic. Is he going to start first, or do I also introduce Dr. Preeti?
I think Dr. Narasimha can start.
Okay.
Sure, madam.
Okay. Over to you, Dr. Narasimha. Welcome.
Thank you, madam. First of all, I would like to thank Shilpa madam for chairing this session, because your extensive experience will help giving more insights into this session. And Kathy madam for moderating, and Ritambara madam for inviting me for this presentation. And thank you, Sudhir sir, for taking up this activity. Let me share the screen. Is my screen visible, madam?
Yes,
Yes, it is. Please
Oh.
go ahead.
So my presentation will be predominantly from the chapter that I have written in the book on women's mental health, which is from our teacher, Professor Prabhachandra. So in this book, I have I had an opportunity to write a chapter on substance use and externalizing disorders in women in the Indian context. It's a wonderful book, which Madam has put all the effort, both in terms of her experience and a lot of work that she has done in the area of women's mental health. If you have an opportunity, I would definitely recommend all of you to, this is available on Amazon, to purchase this book and read. So I have quoted a lot of references from this chapter, in this chapter, so I will not be citing any references because all the references that are quoted in this chapter are available in the book. So in this presentation, for the clarity, I'm not quoting any references. So this is our team at Nimhans. I think you might be knowing all of the team members, and I'm junior most in the team. And this is the left side picture is Center for Addiction Medicine, female addiction medicine ward. Few centers across the country has a separate ward for women with substance use disorders. And the right side one is the Department of Psychiatry. If you have an opportunity to come to Nimhans, please give me a message. I will be happy to uh, host you or show you the wards. So before I think before people start coming in, I thought I will start with a presentation because sir has told that generally when we talk about addiction, it is predominantly men that comes to our mind. But doing DM at Nimans and seeing women with substance use disorders, anyone who has worked with women with substance use disorders, people will realize how difficult it is, because the severity with which they come to the hospital at the severe spectrum of problems with which they come, it is extremely difficult. JRs at the end of the posting or SRs at the end of their course, they tell that handling one patient who has women with substance use disorder is equivalent to at least 4 or 5 men with substance use disorder in the. So we have a 20-bedded women's ward and 60-bedded ward of men. So it is as difficult. It is that difficult. So this is one of the presentations. Again, most patients who present to us in the ward have similar kind of a profile. So let's start. I will give a brief overview of this presentation. Then we will continue the presentation, and at the end we will see what happened with this patient. So this is a 34-year-old married and separate graduate, currently unemployed, from a middle socioeconomic status, from a urban background, from a metro city. Temperamentally had an easy childhood. She was an easy child, but family history, there was a depression in first degree relative. And when it came to personal history, there were adverse childhood experiences. High risk sexual behavior during adolescence was noted. She got married very early. Again, 21 years was not something that is usual time for marriage, but it was an impulsive marriage. And she decided one day, short relationship, but she got married with that relationship. There has also been strengths in her personal history. She had good at academic uh, performance, and she did a lot of internship. She started working very young, 15 years of age, did a lot of freelancing work. Till 27, things were going extremely well. Suddenly, after the birth of the second child, during postpartum period, she had seizures, following which she continued to have seizures on and off. Last episode of seizures was at 31 years of age. But since then, she started having non-epileptiform seizures since the age of 31. And after 27 years of age, she started having depressive episodes. And these depressive episodes, she had a proper depressive episode, which requires a consultation in 28 years of age. That is around the end of the postpartum period, less than 1 year of the postpartum period. And following which she had multiple episodes of depression, but these are all brief lasting. Very differently, she started using cannabis and tobacco at the age of 31. And that is the time where she also got separated from her husband who had alcohol dependence. This continued, and at the presentation when she came, there was increased fearfulness, hypervigilance, predominantly in the presence of men. And these symptoms were there at least for last 1 month. And major concerns when she presented was there were a lot of impulsive decisions. There was excessive and impulsive online shopping, high-risk sexual behaviors demanding disregard for others, all of which became prominent in the last 3 years. And these were episodic, and these episodes lasted, the duration of each episode was not very clear, but these symptoms were there predominantly for last 3 years. During this period, she left 2 children with husband, who was in a different metro, and there has been multiple legal problems. There has been a lot of family discord. There are episodes where she got into trouble with the police. And during the same period, in the last 3 years, she started reporting that she is not happy with her gender and she wanted to change her gender, during which she started using testosterone for 2 years, for a period of 9 months. But one thing that needs to be noted during this period is there has been comorbid cannabis use and all these behavioral changes have been observed. So when she came during in the initial part of the MSc, it was labile mood was there. There was a lot of disinhibited behavior, and these symptoms of dissociation continued. And she also reported when we talked about cannabis, it was in a pre-contemplation stage, and for tobacco, it was contemplation phase. When she presented, absolutely we didn't had any idea what she was going through. There were symptoms of there were seizures. Following seizures, everything went differently. There was depressive episodes. Then she spoke about gender dysphoria. Then there were a lot of personality changes. Then there were also a lot of mood symptoms. And on the top of that, there has been cannabis use, cannabis dependence, and separation, a lot of legal issues. So it was quite challenging for us when she presented. And this amount of challenging presentation is something that is very common, especially with the this kind of challenges we generally don't see when men with substance use disorder come to our hospital. Definitely we see, but not most women who come with substance use disorder come with these kind of challenges. So I'll talk about this at a later stage, towards the end of my presentation. So let's dwell into the presentation per se. So I have divided my presentation into 3 parts. For each part, there is a small quiz. This is going to be an online quiz. I will tell you about this quiz in the subsequent slides. So the objective of this part is to tell you about what is new in terms of the epidemiology. I think one of the chairperson has told about the changing patterns of epidemiology of substance use. Is there difference in vulnerability? Why harms because of substances more in women than men? So let me show you the. So this is going to be an interactive session. So I want people to scan this QR code. If you are logging in through your system, please scan this QR code through your phone, or you can also go to something called as slido.com and use the code as women. Then you can log in. And once you log in, I would request to answer to this question so that I know that right now we have number of participants that we have is 15. Sorry, because I am also presenting, I could not see the number of participants. We have 35
35.
Yeah. Yeah. So we have 35 participants. So please, which is a common substance for which women seek treatment in your practice? Right. So that this is a kind of platform so that you get used to this system. Sorry, you can continue. I think 12 participants have responded. Tobacco. Smokeless tobacco. I think some participants have typed message as a message. I would request to log into this thing and type so that we have more activities coming up through this platform. So that you can get used to this platform. This question is to basically get yourself used to this platform so that you can participate more interactively in the further discussion. Okay. I think 15 out of 35 have responded. Madam, should we wait for 1 more minute for people to respond?
I think we can go ahead. People are
Sure.
new to this, so I think they're taking time and some are typing. So
Yeah,
three have typed also.
yeah,
So you can say 18 have responded.
yeah. So I think 15 is the response, right? So the most common treatment seeking substance is tobacco. Now I would request everyone to join quiz. Again, you can scan the QR code or you can open Slido on your phone, slido.com, and use a hashtag women so that you can join the quiz. These are simple quiz. This is going to be a simple quiz and it's going to be interesting. So your responses are dependent on, so it takes care of how fast you type. Second, it also based on the correct responses. I think 11 people have joined. 12. Okay. Should we start or should we wait for more people to join the quiz? 13, 14. Okay. So we'll start the quiz.
Yeah, people are getting the hang of it.
Yeah.
So,
So
yeah,
quiz
please.
has started. Prevalence
Yes.
of following substance is highest among women. Prevalence, is it alcohol, tobacco, cannabis, alprazolam in Indian context? Right. I think 9 people have responded. I think most of them have responded correctly. The prevalence of tobacco is highest among all the substances. Right. Now it's a bit complicated question. Following statement is false about vulnerability of addiction among women. I've given a lot of time so that you can read and answer. Okay, great. 13 out of 17 people have answered. And I think most of you have answered correctly. So the last 3 are correct. Childhood sexual trauma increases the risk. High comorbidity increases the risk of addiction. Environmental factors contribute more than genetic factors. Again, Great. I think this is going to be the toughest question. So the answer is low gut ADH. We'll be knowing about it. Purposefully I kept all the above. Okay. I think Anusha, Dr. Anusha has got 3 out of 3 correct. Claps for Dr. Anusha. Yeah. So now we will have this kind of quiz after every objective. So we are going to make this session more interactive by having this kind of quiz. So please do participate. As I told, I will be talking about 3 aspects. One is in terms of the epidemiology. Madam Shilpa Madam has highlighted how the epidemiology has been changing. As you have noticed that there are 2 major studies that has been done in last 5 years. One is GATS2, which looked at tobacco, National Drug Use Survey by AIIMS Delhi, which looked at all the other substances, where tobacco is the highest prevalence, 14.2%, and alcohol use among women has been 1.6%. Again, dependence as per NMHS, National Mental Health Survey, is somewhere around 0.5% of the women are dependent on alcohol. One of the major findings, again, Madam has highlighted this, the gender gap between men and women in terms of the prevalence rates has been reducing across the world. But do we have enough data to tell that this gender gap is reducing? We don't have. And what is surprising is when individual studies are done, like hospital-based studies, vulnerable populations, like someone was telling about the opioids. So the prevalence of opioids among vulnerable population, especially women, is significantly higher. Again, the NMHS megacity survey, although it is not yet published, has shown there has been a lot of urban-rural differences, especially in the urban population. The prevalence among women, especially with common substances, seems to be much more higher. So what will give more information is the National Drug Use Survey 2, which is going to start in some days, and National Mental Health Survey 2, which is already ongoing. Although the National Family Health Survey is ongoing regularly, which taps into alcohol and tobacco, but some of those findings, we take it with a pinch of salt because of some of the methodological issues, but these 2 surveys are going to give us more data. Coming to the second objective of this section is there a difference in vulnerability? Definitely yes. For example, one of the questions where we spoke about the estrogen, tobacco, especially the metabolism of tobacco, is something that is influenced by estrogen, which again increases the risk of addiction. Similarly, the metabolism of cocaine and the reinforcement, the psychodynamic property of action of cocaine, is again influenced by estrogen. Again, there is an increased risk of addiction because of the estrogen. Specifically in terms of both metabolically, that is pharmacokinetically and pharmacodynamically. As I told that in men, the genetic vulnerability plays an important role. When it comes to women, these are the environmental factors. Especially this is true in Indian context. We see a lot of environmental factors playing a role in terms of the dependence, development of dependence. What are the environmental factors predominantly? The availability of drugs, the education status. Low, we see the prevalence rates higher in low socioeconomic status, lower education, and in families where the family environment is disturbed. 2 major psychosocial factors that has been found significantly associated is trauma during childhood. The other group is the elderly. Widowhood is again a risk factor for substance use and dependence. Comorbidity is significantly high. Depression, anxiety, PTSD, eating disorder. Predominantly internalizing disorders are predominantly high in women compared to men who has more of externalizing disorders. This is one interesting thing that the harms when it comes to women is significantly high compared to men. So for example, a 150-pound person, both men and women, drinks 50% of alcohol, around 4 ounces. The amount of alcohol that comes in the blood alcohol concentration is somewhere around 0.1 gram percent for men, and it is 0.12 gram percent in women. So that's why the organ damage is more in women compared to men. there are multiple factors which lead to increase in this blood alcohol concentration. One is the gastric emptying. In women, it is 42% lower. There is high first pass metabolism in liver in men, and the volume of distribution, because of high body fat and low body water and low volume of distribution, the blood alcohol concentration is high. The other important thing is gut ADH activity. The ADH is something that breaks down the alcohol and metabolizes. That activity is lower in women. So because of this, there is a higher blood alcohol concentration, and because of this is one of the factors. The time to develop dependence is less among women compared to men, and the severity and rate of complications are also more. So this is the first section. In the second section, I will be talking about two important aspects. What are the differences in clinical patterns? And we will also try to understand comorbidity, especially externalizing disorders. So there has been a lot of research that has been done at NIMANS to look at the vulnerability model of addiction, where just treating addiction is not sufficient. We need to look into underlying vulnerability. So there is a understanding that addiction is an epiphenomenon of underlying vulnerability. So just treating addiction, the outcomes doesn't seem to be that good when it compared to when you treat both vulnerability and also the addiction. So we will dwell into these two topics. Before that, again, I would request all of you to join the quiz. I think 18 people have already joined. Shall I start the quiz? People are there. Shall I start, madam?
Yes, please. But I only lost mine, so I'm logging in again.
You can log in again. So I can
Yeah.
request people who have lost can log in again. Maybe 30 seconds. You can log in. Okay. Madam, if you have logged in, then you tell me okay, then I will move forward.
It gives
Yeah,
the message,
please.
get ready.
Yeah,
Yeah. If you have already logged in, you are ready.
yeah.
Okay.
Dr. Uma, you have to scan the QR code.
Okay, actually, I've joined this via my mobile, so now I have to join this on the laptop and then scan.
Okay. I think 9 people were able to answer it correctly. 9 people logged in and answered. So this is something called as telescoping. And alcohol harms paradox, just for explanation, is that if you see people from BPL or below poverty line or underprivileged people versus APL, above poverty line or privileged communities, when both of them consume alcohol at the same quantity, people from low socioeconomic status suffer more harms compared to people from a higher socioeconomic status. So that's called as alcohol harms paradox. Again, narrowing effect is a nothing that is not related to this. Reverse tolerance is because of a lot of other factors. For example, people who drink 1 unit of alcohol, people earlier drinking 6 to 10 units of alcohol, when they start drinking 1 or 2 units of alcohol, they get the same effect. Generally seen in people with head injury and that kind of thing. That is reverse tolerance. Right, next question. Yeah, I think most of you have answered correctly that intimate partner violence increases the risk of PTSD. Last question. Yeah, I think the first response is correct. The self-assessment symptom severity ADHD is a tool specific to understand ADHD in women. And the ADHD in women is associated with predominantly inattentive type. Okay, I think this time we have a different winner, Swati. Congratulations, Swati. And Anusha lost the first place by 5 seconds. We have more more quiz that is going to come. There is 2 more quiz that is going to come. Okay, so let's move on to the presentation. So we spoke about what are the differences in clinical patterns compared to men and men versus women. One of the, again, there is some research from Indian context, there is research from Western context. So this table gives both the a combination of both the research. The onset of substance use, especially in men, is during late adolescence, whereas in women it is later age compared to men. And in men, it is predominantly because of positive emotion, but among women, it is to cope negative emotion or stress. Although this is not completely true, but whatever the studies that has been done in Indian context, it is predominantly, again, there is a bifurcation in low socioeconomic status, whatever the population that we are seeing. These are elderly women who have a lot of problems. But when it comes to younger population from high socioeconomic status, it is predominantly early age. Binge drinking rates are higher in men. Tobacco use predominantly smoked form in men and smokeless form in women. Again, this is from Indian studies. Opioid use, injectable form is the most commonly used form in men, whereas women use predominantly prescription drug use or inhalational form. And illicit drug use, although it is prevalent, but less compared to men. This is something telescoping, which is the time between the onset of substance use versus becoming dependent. Also from the onset of substance use versus perceiving harm. So that this time is shorter in women compared to men. Again, the reasons we have discussed because of various other factors. So this is telescoping is something that is common in women compared to men. And the comorbidity, as I told, externalizing disorders are common in men, whereas internalizing disorder, anxiety and depression are common in women. Women has more social impairment, whereas men has a lot of legal problems. The quality of life impaired significantly in women, and the mortality is fivefold higher in women compared to threefold in men. This is comparison to general population. And when it comes to treatment entry, men are more likely to seek treatment. Access to treatment is poorer for women, whereas better for men. And when it comes to treatment settings, men are more likely to seek treatment in specialized settings, whereas women in mental health treatment settings. There has been a lot of barriers to seek treatment because of stigma. Other countries, they have shown about the childcare responsibilities and lack of family support. Outcome of treatment, again, which is worse in women compared to men. Coming to comorbidity, this is something that is a treatment principle at NIMHANS, and across the world there has been a lot of research on it, that comorbidity is a rule rather than an exception. So we always need to look for comorbidities, especially psychiatric comorbidities. Women with substance use disorder has greater psychiatric comorbidity compared to men. And as I told you that internalizing disorders are very common, about 1 in 4 women has this internalizing disorders. This is something both among substance using women, also among wives of or spouses of substance using men. The intimate partner violence is significantly high, which is around 40 to 70%, whereas in general population it is 17 to 30%, which again increases the risk of comorbidity, which is post-traumatic stress disorder. And these externalizing disorders are not just the vulnerability for them to develop addiction. Once they develop addiction, the externalizing disorders are also comorbid. So what are these externalizing disorders? So childhood externalizing problems in general has been linked to initiation of substance use. So adolescent substance use is linked to childhood externalizing disorders, which are predominantly ADHD, ODD, conduct disorder, antisocial personality disorder. Substance use disorder also is considered as an externalizing disorder, but these disorders increases the risk of substance use. And symptoms of these disorders often appear in childhood or early adolescent. And one more important factor is the environment, which is the parental substance use, raises the risk of substance use in children, both through modeling, also because of a lot of changes in the family dynamics, which makes them more vulnerable to develop externalizing disorders. And these externalizing disorders, specifically in females, have a different presentations and have different outcomes. So the most common externalizing disorders, although internalizing disorders are more common in women, but among treatment seeking population, what we have seen is the externalizing disorders, especially ADHD, being more common. And how it is different is the inattentive type is more common in women compared to men. Most people present late to the treatment, or the treatment seeking, the treatment gap is high, often misdiagnosed as personality disorders, also as internalizing disorders, because most people have comorbid internalizing disorders, a lot of anxiety and depression when they go through ADHD. So when they present, they don't present with ADHD, but they present with anxiety and depression. So there might be a misdiagnosis. And when women have comorbid ADHD, the cognitive impairment seems to be high. Early sexual activity, the sexual encounters seems to be early compared to general population. Encounter bullying leading to school dropout and poor self-esteem. One important observation, especially among women with ADHD, is hormonal changes worsen these symptoms. The comorbidity of, as I told you, the internalizing disorders is high, which again leads to substance use disorders. So women with ADHD, this is the tool that I was talking about, which is self-assessment symptom inventory, which is a detailed inventory. Again, it is not used for diagnosis, not used for screening, but it helps you understand in what domains the problem has, the woman is suffering problems related to ADHD, both in a childhood context, adult context, in the adult context also when there is a comorbidity. So this is one important tool that you can use in your clinical practice. It is available, freely available online, but if you are using for research purposes, you might have to write to the author. Very extremely useful tool, CLASI. Then coming to the next last objective for my presentation is what are the commonly used screening tools and what are the pathways to seeking care and treatment. I have enlisted all the screening tools, but these are screening tools are generally used in the populations like general medical setting. All of us being psychiatrists, so we will predominantly focus on diagnostic tools like ICD-11 or DSM-5. These screening tools like for alcohol, audit C, CAGE, MAST, all these things are, for example, tobacco, FTND, Fagerstrom test. Fagerstrom test is also available for smokeless tobacco. These are commonly used in a general medical setting. For especially for pregnant women, there are other tools which can be used in general medical setting, because again, screening for substance use is something that is taken at priority in other countries, but at least in Indian context, among pregnant women, especially from vulnerable populations like tribal communities, there some of these tools might be of help. Again, if the prevalence rates in the some of the populations is high, these tools might be used, can be useful. One is Tweak is commonly used, TES is commonly used. So these are two important tools. Again, there are a lot of tools for measuring intimate partner balance, which I'm again not presenting in this presentation. Again, most women come, when they come to the treatment setting, they just don't come for treatment of their addiction. They have a lot of other issues, starting from medical issues, when they have a lot of comorbidities, especially when they come to a context of specialized addiction treatment facility. Along with that, cultural and language related needs are also very important, because when people come from a different part of the country, especially when they come, NIMHANS being a center where people come across the country, these cultural and language needs are very important. Again, that is also true in places where there is a lot of migration. So when migrant workers come to Bangalore and work here, I have seen when I was working in state of Jharkhand for some time, I have seen a lot of people migrate to Gujarat, and the substance use among the husbands migrate to Gujarat, and substance use among the wives seems to be increasing when there is migration to other part of the country. So cultural and language needs are something that needs to be taken into consideration. Again, there are a lot of barriers to seek treatment. One of the major barriers is the systematic barriers, which is there are no women-specific treatment centers. So that is one. Specifically, when women come for OST, opioid substitution treatment, they have to stand in line along with men, and they have to follow all the rigid schedules, which becomes difficult for them to seek treatment. So we have OST center where uh, at least at this point of time, women come in a separate timing compared to men, but it becomes challenging for women to seek treatment when they have to stand along with men. And societal factors like stigma plays an important role. Again, if you start talking about stigma, there is a lot to talk about. Among individual factors, most people when they come to our treatment center, one of the major things that they tell is lack of awareness about the treatment. So most people, the time to seek treatment is significantly high because they are not aware that there is treatment that is available. Apart from that, there are other factors like immigration, what I was talking about. So coming to the presentation that I spoke in the initial, as I told that it was very challenging for that patient to engage. So most of the time in the initial days went on engaging the patient. Uh, and we kept a diagnosis open. We didn't label the patient as bipolar or personality or PTSD or gender dysphoria. We kept the diagnosis open. She was on many medication when she came. So we stopped SSRIs. Then we thought depression seems to be there because it started with depression. Then when we switched to desvenlafaxine in the ward, there was a switch, and she started having mania symptoms. Then we stopped desvenlafaxine and we rationalized the medication. Finally, after almost 3 weeks of intensive evaluation, we understood that although it started with depression and seizure disorder, her cannabis use again, it started off with depressive symptoms. The cannabis use has flared up a lot of things where these symptoms related to gender dysphoria started coming. The symptoms related to the manic symptoms were precipitated because of cannabis use, and a lot of legal issues happened during the cannabis use. So once we stopped her once the cannabis use was stopped, and then she was put on these medications, she started all the other symptoms like gender dysphoria has vanished. There are no further dissociative symptoms. The seizures were under control, and now she underwent intensive psychotherapy for almost a month time at NIMHANS, and then although she recovered well in terms of her the mental health condition, but whatever the harms that she has sustained over a period of time, for that recovery to happen, it is even at the end of 1 year, the domains related to occupation, family, recovery is still slow, but it has been building. What helped is continuous engagement with the patient and the initial motivational interviewing that has happened. Although she was in a phase of hypomania during that time, when we were able to engage her in treatment once she is slightly better, helped us to help her, or made us to help her to maintain well. So this was the presentation of that case. I think my presentation is almost end. I have a presentation. I have quiz for Dr. Preeti. I will finish Dr. Preeti's quiz also. Then I will hand over my uh, screen to Dr. Preeti. So if everyone has joined the quiz, shall we start? Anyone can tell me, shall we start?
Yes, please.
Yes. Okay. So we have 22 participants. Yes. Yeah, I think Dr. Preeti, you want to pitch in and tell the answers or?
Actually, answer, I think it comes automatically, right?
Yeah. So it's agonist maintenance therapy. I think Dr. Preeti will be telling in her presentation.
Yeah.
Yeah, I think this was covered in one of my presentations. Yeah, I think most people have answered correctly. Yeah. I think this is the final question. Yes, most people answered correctly. Okay. This time it's Dr. Gaurav. Congratulations, Dr. Gaurav. And right. So I think this is my presentation, and we have a CME in upcoming in the month of March, as Dr. Benegal sir is retiring in the month of March. So we have a CME on that occasion. And we also have some of the courses on motivational interviewing, which has been launched today on relapse prevention for substance use disorder. That is my presentation. Thank you for giving me this opportunity. Over to
Thank you,
the
Dr.
chairperson.
Narasimhan. Thank you so much for an excellent presentation. I think you took us from epidemiology and clinical presentation, differences in men and women, substance use, vulnerabilities, externalizing, internalizing, ADHD. So anybody attending now would go back to their clinics or practice or hospitals will have a different perspective looking at women with substance use. So thanks a lot. And I'm sure people will have questions, but that would be at the end of the second presentation. So we welcome Dr. Preeti Kathiresan, Assistant Professor at the Department of Psychiatry, AIIMS, New Delhi. Her areas of interest are geriatric and addiction psychiatry. She is the member Public Awareness and Advocacy Committee, International Psychogeriatric Association. She's the member secretary of ISAM Next, chairperson of website committee of ICAM, master trainer for OST program under National AIDS Control Organization, a Ruth Fox Scholarship Award by American Society of Addiction Medicine in 2021, an International Best Research Poster Award at NIDA CPDD International Research Poster Session in 2020. So we welcome Dr. Preeti and we are eagerly waiting. We've already done the quiz. So we are looking forward to your presentation. Over to you.
Thank you, ma'am, for the warm introduction. So I'll just share my screen. Can everyone see my screen?
Yes, we can.
Okay. Thank you, ma'am.
Can you please make it full screen?
Yeah, I have made it.
Yeah.
Thank you. So now I'll be talking about the management of addiction in women. So initially I'll be
Dr.
talking.
Preeti, your volume is a little low.
Okay, 1 second. Oh, good. I'll just try to come near the laptop and speak. Is it audible now?
Yeah, you're audible, but it's a little low volume.
Okay.
Go ahead.
Thank you. So I'll be talking initially about the general principles of management related to addiction and then the management challenges which are specific to women with addiction. So coming to the general principles of management of drug addiction in general, so we all know that the effect of drug use occurs over multiple domains. It affects the physical, psychological, social, legal, and interpersonal domains. So as Dr. Narasimha said, in women, it is actually even more complex that it affects the harms due to substance use occurs very early in the women substance users than in the males. So we have to have a holistic perspective towards the curves. Since the effect of drug use occurs over multiple domains, treatment should also be able to address the multiple domains of this problem. So if for the medical complications that occurs, we have to go for the withdrawal managements or the substitution therapies, which we'll be discussing later on. And for the psychological complications that occurs, we have to go for motivational enhancement therapy and cognitive behavior therapy. And also there are a lot of social issues that occurs in the case of females with substance use disorder. So we can have some women support groups in related to the same. Can you hear me now better? Hello.
Yes. Please go.
So no single treatment is appropriate for everyone. So individuals are at different stages of treatment. So when a female drug user comes to us, sometimes we have seen patients who are brought in by the family members. So there was one female patient who had been having significant conflicts with her parents, because of which she started her drug use. However, she was not willing to come for treatment. So it was her mother who brought her. So there are, even though in many cases the females come on their own, but in some cases we have seen that people are brought in by other people. So even when they are coming, so similar to the male drug use, we see that people may be at different stages of change. Some may be thinking about giving up their drug use. Some may think that drug use is not a problem. Some may be ready to give up the drug use altogether. So we should not, when we are treating the substance use also, we have to individualize the treatment according to the motivational stage they are in at that time. So no single treatment is appropriate for everyone, and we have to give a menu of options. For a person who is not willing to leave the substance together, we go for motivational enhancement therapy, or we go for substitution treatment so that they at least reduce the amount of drug use. And once they start engaging in the treatment, and once we have reduced their harm, then we go for the further intensive treatment. And treatment needs of an individual can be different at different stages of recovery. So during the initial stages of treatment, the predominant focus is on relieving the person from the withdrawal symptoms that occurs when a person stops taking the substance use, and also from relief from the crisis situation they are in. And at that time, the person may not be sure about how they will be able to abstain from the substance use or a very long time. They may be unsure about the recovery. So once that withdrawal phase is crossed and we have helped them manage the crisis, then therein comes the intermediate stage. Sometimes certain medical comorbidities may need to be taken care of in the initial stage itself. However, most often we see that when a person comes to us in a crisis situation, if we ask them that you have to go and get your medical comorbidities also treated, then only we will start, then the person will drop out from treatment. So the initial stage will be focusing on helping them in the crisis management. Then the intermediate stage will be the addressing the medical comorbidities and addressing the social issues. So we have seen that there are a lot of complications related to substance use. So we go for the management of the other comorbidities. And in the long term, we also focus on preventing the relapse to the drug use and then helping them in improving the social ties. So in the immediate goals, it may be either detoxification or helping with the psychosocial and medical crisis. During the short term, we'll be helping them manage their medical or comorbid psychiatric illness and reintegration with family. And then in the longer term, it will be relapse and reintegration in the society. And so this is what we mentioned, the treatment needs of an individual are different at different stages, and hence it is necessary that we keep on continuing to assess and monitor. And the recovery from the drug dependence is usually a long-term process. So it is not a one-time phenomenon. We have to have the person in follow for a very long time. So similar to a chronic medical illness like diabetes or hypertension, what has been seen that drug use occurs due to multiple factors. So it is not only biological factors like hereditary, it is also due to environmental factors, it is also due to the social factors. So there are multiple factors that is involved, and all of them require long-term treatment similar to diabetes and hypertension. And the rate of adherence is also similar. That is, there is a higher risk of relapse even in the persons with diabetes or hypertension. Similarly, in drug dependence also, there is a very high risk of relapse. So the longer the duration, the better the outcome. So the duration of addiction, the severity of dependence, the complications, all this lead to negative outcome. However, the availability of social support and being in the treatment for a longer duration has been associated with better outcomes. So we all know that drug use is characterized by relapses and remissions. So this is one thing, it happens with any drug user. However, in the females, it has been found that once a female is initiates treatment, so there is a lot of barrier before a female comes into the treatment. But however, once the female initiates the treatment and completes it, the chances for relapse is relatively less compared to males, and even the severity of relapse is relatively less compared to males. However, the initiation of treatment is very, very difficult. So drug addiction has always been seen as a chronic relapsing disorder. And it is similar to, again, depression and hypertension, diabetes and hypertension, in which also we have found that people sometimes take, they are non-compliant to medications, they take food which leads to hike in the sugar levels. Similarly, in addiction also, people take substances and it is a chronic relapsing disorder. At the same time, with long-term treatment, these relapses become less. So these relapses do not necessarily indicate that it is a poor motivation of the patient or the ineffectiveness of the treatment. It is necessary for us to recognize that it is part of the illness, and hence we should be prepared to manage the same. And treatment is more effective if the individuals participate in the decision process rather than we dictate the treatment to them. So we should be having an active discussion with the patient on the modality of treatment, whether it has to be an inpatient treatment or the outpatient treatment, or what kind of treatment, whether it should be just pharmacological management or psychological management, or how it should be done for on the OPD basis or inpatient, or for how long. All this should be done with the in discussion with the patient. So treatment should never be given forcibly or under coercion because they are ineffective. And the last principle which we use in the case of substance use disorder is that we try to give a person-centered approach. We know that everyone have a different need. So each person is unique. Each person will have different complications. So we have to help them manage the complications based on what they are suffering and what is more important for them. So treatment should also address the associated comorbidities and psychosocial issues and not just the addiction part for them to recover from addiction. So when we come to females specifically, females with addiction, there are certain challenges which are unique to females. So as Dr. Narasimha said, there is a telescoping phenomenon. That is, even with a smaller amount of substance use, there is a higher amount of complication that occurs in the females. There is more medical complications. So it has been found that females there is a higher risk of engaging in sex or selling their body for getting money for using the drugs, because of which there is a higher risk of occurring sexually transmitted infections. Also, as we have seen that even a little amount of a drug can lead to more effect and more harm in the female. So the medical complications are more. Again, the psychological complications are again more, because as Dr. Narasimha pointed out, that internalizing disorders are very common among females, and there are and they also suffer a lot of trauma, because of which the PTSD risk is very, very high. And there is also a lot of social problems that occurs, in which there is a lot of stigma, there is a lot of societal barriers that occurs, and also the behavioral problems. And again, there is more prevalence of comorbid psychiatric disorders, which leads to challenges in the treatment, and there is more risk of exposure to trauma, which is both physical or sexual trauma. And it is not only that, what happens is, in a male who is using substance, most often everyone in the family would asking him to leave the substance. However, in the case of a female, even though there is a lot of stigma, what happens is a significant person in her life, either it is the spouse or a boyfriend who is also taking substance. So because of which, even if she wants to leave the substance, if the other person is taking, the risk of relapse is very high. So these are certain challenges that are unique to females. Also, as we have seen, there are certain gender difference in the way the body metabolizes the medication that are used for treatment. As the nicotine replacement therapy, which we use for tobacco use disorder, the body metabolizes nicotine very fast, because of which it becomes little ineffective, and hence the treatment outcome with NRT among females has been found to be worse compared to males. And also females, there is during pregnancy and breastfeeding, there is a risk of exposure of the drugs to neonates. Hence, we have to take care of that part while managing addiction in the females. And there is also parenting role. So if a female, in that context, if a female is taking substance, then she will not be able to adequately take care of the child, because she'll be using the finances to fund her drugs, or she'll be under intoxication. At that time, she will not be able to take care of the child. So there is also an effect on the child that happens when it comes to females. And there is also again more barriers to treatment, as Dr. Narasimha pointed out. So how to manage this? What is the way forward? So what has been found is gender responsive approach to the management of addiction in women is what is said to be most effective. So do we need to have, most often this is one of the thing which comes, that females do feel uncomfortable coming to a drug addiction clinic. So is it necessary for us to have a female only treatment, or is it okay if we have a mixed gender drug treatment programs? So what has been found is that when the female only treatment is there, the probability of the treatment completion is higher. However, coming back into the treatment was similar, even if they were in the female only group or in the mixed group. And there are multiple studies which have shown that there has been no significant difference between the facilities which has only women's only program and those which have a mixed gender program. So what is it that is actually needed? When we have talked to the patients, usually most females with drug use, they do prefer to have a same sex or female only groups compared to the mixed gender groups. However, if you see in the long term, the treatment outcomes have been similar. So what the females say is that when they talk to female therapists, they feel more comfortable, because they're able to talk multiple difficult topics like relationship issues, and they are able to focus on themselves rather than on the men in the group when going for group therapy. What is more important, it has been found, is having a gender responsive program. Just treating them in a female specific setting without giving them any adequate knowledge or what else needs to be done, because most of the research, most of the guidelines, most of the research in the medical literature, you have seen that they would have predominantly focused on males, because the substance use or the addiction is more common among males, because of it most of the literature either take the males, exclude the females, or even if they try to take both, most commonly it is biased towards the males. So because of which the female specific treatment related literature is relatively sparse. So what has been found is having just a treatment service in which there are females, but there is no women specific treatment services, is as good as having a mixed gender treatment service. In order to improve the treatment services, what is more important is that we need to have a gender responsive service. So what is the gender responsive service? So we all know that there is a difference in the basic psychology between males and females. So females usually give more importance to relationships, and hence, but that is something which is which is also getting damaged when it comes to female addiction, because they most often they start drug use because there is a close partner who is taking the substance, and they would also have suffered trauma from their close relatives or close friends or whoever they trusted in. So when we are going for treatment also, we have to adopt relational approach. So the treatment environment should be more supportive, safe and nurturing. So it should not be confrontational. It is true for male drug addiction also, but this is more important when it comes to female drug use treatment. So at AIIMS Delhi, in the National Drug Dependence Treatment Center, we have a women clinic also, which runs on every Saturdays, in which we have a separate dedicated time and day in which we are treating the females. But it is in the same hospital where we are also treating the males, but the clinic is separate for women. And we have the female faculty as well as the male faculty who is looking after. And the trusting relationship which a female patient builds with the staff during the treatment has been found that it helps in repairing the hurtful relationship in the past, and it helps them to come out of the trauma. At the same time, we also need to ensure that we maintain the limitations and boundaries, especially when it is related to the touch and safety of the patient. For example, if a patient is crying in front of us, and if the person, if we even try to touch the patient, we have to see whether we have to also look into the non-verbal communication of the patient, whether the person is comfortable with that or not, because the person who has already experienced trauma in her life may feel that even that small touch, even though we may be trying to help her out, it may trigger her. So we have to be mindful of that. And having a female staff or family member during the treatment, especially when the therapist is male, actually helps the person feel more comfortable and safe. That helps them in the treatment. And we should also make sure that the patient has access to exit freely so that she feels safe. And also, it is necessary for us to adopt a trauma-informed approach. So what does this trauma-informed approach means? So we have to understand that, as Dr. Narasimha pointed out, that nearly half or even more than that, up to 70%, nearly 3/4 of the persons of 3/4 of the females who take addiction have suffered some or the other trauma in their life. It is necessary for us to understand that trauma play a major role in the life of women seeking addiction service. And we should look into what had been the past trauma and whether the person is also going through current trauma in her life, and help them developing the coping strategy. So trauma-informed approach doesn't mean that we should make the person narrate all the trauma that is happening. It is not mandatory. So it is just that we should, the person may not reveal the trauma during the initial stage. With development of rapport, the person may tell the trauma in later stages. So we should consider trauma when we are making assessment and treatment plans. So if you're going to plan some treatment approach, we should have in mind that if she goes back home, is she in a safe environment? Is it possible that the person may take away the medicine which is being given to her? What other options can we do for her? So whenever we are doing the assessment or the treatment plan for the patient, we should keep all this in mind. And we have to try to avoid any reactions that can trigger trauma in her, or it can re-traumatize women. That should be done. And the staff behavior, especially towards females, should be adjusted in that manner, because even a small trigger can again re-traumatize the woman. So what we do in our community clinics, we have a lot of female patients also coming together. So when they come, we prioritize them. We ask them to come yearly, even while giving the medicine like methadone. We give them in a yearly, we give them faster compared to men. And we also have some flexible timings if if the female patients are coming. And we have to allow them to express their trauma and manage the symptoms successfully. And as Dr. Narasimha pointed out, there are a lot of co-occurring disorders. So we have to manage the psychiatric as well as the medical disorders along with the substance use disorder, and integrated treatment approaches needed. It has been found that when multiple services are provided together under one roof, the chances of treatment retention is more better in case of females. And we have to recognize that in the case of females, the parenting and the caregiver role is also very, very important. So if we ask a female that you have to come only during this fixed time, when she has to do some work in the home, for example, that might be the time when she has to cook for her, or she has to take back her child from the school. So we have to be responsive to the concerns of the patient, and if needed, we can keep the timings flexible, and we can also allow the children to come and come on site and be with her when she's coming to take the medication. So these are some flexibilities that we have to and make the treatment gender responsive to help increase the treatment retention. Coming into the medications, again, we have to take into consideration the biological changes that can occur in females, as Dr. Narasimha pointed. So with changes in the menstrual cycle, there can be changes in the treatment response. There can be increase in craving during certain phases. Again, since most of the literature has been on men, there has been no literature that has tried to find out whether, or maybe very less research that has tried to find out whether the treatment the treatment needs related to the medications also changes along with the menstrual cycle. Maybe this may be one of the research which we have to take for the future. And coming to therapist characteristics, majority of the women had actually preferred female therapists for the treatment. And usually females look for trust and warmth in the relationship with the therapist rather than a therapist who is going to give them a solution for their problems. So even when we are going for, even when we know that they have gone through a lot of trauma in their life, just providing a supportive approach, just listening to them, just allowing them to ventilate has been found to lead to a better improvement in their treatment rather than rather than when you are able to provide all the solutions. So it should be a non-authoritarian attitude and approach and not direct them for treatment. And the therapist should have confidence and faith in the abilities and have a non-judgmental attitude. So does it mean that males cannot be a therapist? No, it is not that. So the females, the female patients usually prefer a female therapist, but some people have said that it is also necessary that we need to have some male staff, because the females actually look upon male role models because they have been subjected to trauma. Sometimes they look upon the male staff as a male role model for their kids, or someone who, when they start to build trust, that there are some men who can be trusted also. However, in that cases, the male therapist or male staff who is there have to be mindful that their anger, the autonomy, or the power can have greater impact on the female clients, and they have to make sure that this does not impact or re-trigger the trauma. So we know that sometimes while in the addiction treatment clinics, sometimes the male staff may sort upon the patient. So that has to be relatively less in the females. It is definitely not acceptable with any patient, but in the case of female, it is even more important. And so this is the main principle of management. Very briefly of the pharmacological management, it is not much different in the females compared to men. Because again, the literature has focused not specifically on females predominantly. It has been overall mostly common for everyone. So for NRT, we have nicotine chewing gums. For tobacco use disorder, we usually go for either NRT, bupropion, or varenicline. So I'm not going into the details. It is on the slide, and most probably, since most of us are psychiatrists, so we must be knowing this. I will just highlight what are important with respect to females. So in the case of nicotine replacement therapy, as I mentioned earlier, so the nicotine metabolization happens earlier in females, because of which it has been found that NRT may not be that much effective in females compared to men. And bupropion and varenicline have a relatively equal effect, or varenicline has a better effect in females compared to men. However, they are not given during pregnancy. So in the Indian guidelines for tobacco use disorder, they have mentioned that during pregnancy, behavioral treatment and without pharmacology should be the first option. And if it is not possible for a female to quit tobacco, then we have to offer them NRT or nicotine replacement therapy. Do not go for nicotine patch, go for nicotine gums, because they are short-acting ones. In the case of pregnancy and lactation, bupropion and varenicline are contraindicated. Multiple guidelines from other countries also report the same, and there is very poor quality evidence about the teratogenic risk during pregnancy. Coming to alcohol use disorder, we all know that there is no safe level of alcohol consumption. So again, I'm not going into the integrities. It is similar in the case of males and female, the management. So we have a fixed dose regimen, symptom triggered regimen, and loading dose regimen. And this is an example for fixed dose regimen and symptom triggered regimen. Coming to specifically in females, alcohol use disorder in pregnancy, no amount of alcohol use is safe in pregnancy. If a person is leaving alcohol, so this recommendation is actually a WHO guideline, which mentions that if a person is quitting alcohol, then we are supposed to offer them short-term use of a long-acting benzodiazepine for the withdrawal management, because during the withdrawals, there is a risk of seizures, which can be even more dangerous. So because of which it is recommended that we have to provide them short-term use of a long-acting benzodiazepine. There has been a lot of literature, with majority of literature reporting that there is no evidence of major congenital malformations. However, the results are again inconsistent, with some studies reporting there is an increase. Most often it is the case control studies which is reporting that there is an increased risk of cleft lip and cleft palate. Again, while looking into the risk benefit ratio, giving them long-acting benzodiazepine for a shorter duration of time is going to be beneficial rather than being risky, and hence it is necessary to provide medication withdrawal management using benzodiazepines. So preferably use a longer-acting benzodiazepine rather than shorter-acting benzodiazepine. The reason being, the longer-acting benzodiazepine, the withdrawals will be relatively less. Otherwise, the shorter-acting benzodiazepine, the duration of action will be short. The person will experience withdrawals, which can lead to difficulty in the patient. And the long-term medications are not recommended during pregnancy because they have been found that some of these medicines have been found to have teratogenic risks, and some have been found to have teratogenic risk in animals, but not major studies in the humans. Coming to the opioid use disorder, so again, it is again similar to men that we either go for withdrawal management using opioid agonist or opioid partial agonist, which is buprenorphine. And for long term, we either go for antagonist and agonist. While coming to the pregnancy part, which is unique to females, so agonist maintenance treatment is the preferred modality of treatment. And Mother study is a major landmark study in relation to agonist maintenance treatment in pregnancy. And it has been found that methadone, so buprenorphine is better in terms of agonist maintenance treatment during pregnancy because buprenorphine leads to lower severity of neonatal abstinence syndrome and lower treatment duration for the child, and the total treatment morphine dose record was also lower. Coming to the non-pharmacological part, so we know that we go for cognitive behavior therapy in the form of either motivational enhancement therapy or the relapse prevention. When it comes to females, again, we have to build their scoping skills more, which should be more focused on emotion. So emotion focused scoping skills to be built up more. And also the non-pharmacological parts should also take into account the comorbid psychiatric disorders. So and the other things that viral markers apart from protein investigations in case of high-risk sexual behavior or high-risk drug injection drug use, and collaboration of obstetrics and gynecology when required, and involving family or the partner in treatment is also important. To summarize, so gender responsive treatment should be offered to all females. So adopt a relational approach, that is the person should have a trusting environment and a trauma-informed approach, management of comorbidities, taking into account the parental roles and other responsibilities, and taking into account the pregnancy and lactation. Coming to the pharmacological management, biological variations in the metabolism of nicotine can reduce the efficacy of NRT, and it is necessary that we also make sure that we know what to do in case of pregnancy. And in non-pharmacological management, we have to make sure that we are providing them more emotion-focused coping skills. Thank you. So I have tried to make it short. I did not go into everything because it is a very big topic in itself, the management. So thank you.
Thank you, Dr. Preeti, for a wonderful presentation, taking us through the approach that should be gender responsive so that we can provide better treatment to the women who come with substance use. So I think at the end of both the presentations, what we've learned is that we have to be a little more sensitive when it comes to substance use in women, take a little more childhood history. There could be adverse childhood experiences. There could be internalizing disorders. And we also know that there would be different clinical presentation compared to men. And when it comes to treatment, though the treatment modalities may be the same, we need to be more gender responsive so that we can treat them better and make them comfortable while they're taking treatment, so that they seek more treatment, more women come to seek help, and we can treat them and prevent further relapse, and we can also get them into a safer environment so that they don't have relapse. So thank you very much. If there are any questions, we can take them. Dr. Khyati, do we have time for questions?
I think we are really running short of time. That's what Ritimbra ma'am also would say. And we are having all compliments in the chat box rather than questions.
Yes. Yes. That's what I thought, that both of them have done such a wonderful job in taking us through the approach of how to assess or how to approach a patient, and how to be gender responsive when it comes to treatment. So I think the brief was like to the T. Both of them nailed it, and I'm sure both of them have shared their email IDs, so people can ask them, contact them separately also. But for me, there was a lot of learning, because they quoted some studies, some newer things, especially ADHD, how it is different, and also certain studies about the risks during pregnancy and etc. So, but what my take on when it comes to women substance use is that we need to go an extra mile when we take that history. And most of them we have found have, like, we presented, as I was talking about presenting in the clinical meeting, we presented 4 representative cases. So one of them had a lot of genetic vulnerability because of a lot of family history. The other had plenty of adverse childhood trauma. Adverse childhood experiences score was like whatever could be the highest. The third one was having intimate partner violence. And the fourth one was pharmaceutical opioids, which was more, I wouldn't say iatrogenic, but it was started for pain, and then later on she became dependent. So these were 4 representative cases that we had presented. So women can have these type of histories, which we need to go into and take care of all these other issues. Like one of them, we had to refer to one-stop center because she could not be sent back. So like Dr. Preeti mentioned about how we have to take care of other problems. So I think we need to be a little more sensitive when it comes to women with substance use, because there's always a lot of package that is behind. And if we miss that, then we have missed the boat. So thank you, and thank you for inviting me here, Dr. Khyati, Dr. Ritambara, and Dr. Bhave, and West Zone Women and Child Subcommittee. Thank you.
So it
Thank
was an
you.
excellent presentation. Both the presentations were excellent by Dr. Preeti and Dr. Narasimha, and the chairing by Shilpa ma'am was also amazing, with so many useful comments. We gained knowledge by that. Ritimbra ma'am, so should I ask Neha for vote of thanks, or do you want
Oh,
any
yes,
questions?
I'll not take more time. Only thing is that I was so occupied. I thought we'll finish our exams by 6 o'clock and I'll be definitely. But right now I'm in the car. I have stopped my car and I'm really looking at all of you. I mean, thank you, Dr. Narasimha and Dr. Preeti, and especially taking this session to one step further. Your Slido quiz was really great. Though I punched anything because I was sitting with those examiners, and what I was doing, I don't know. But I did attend to some of it. Dr. Preeti's management part also, some of it I looked at. It was really very good. And Dr. Shilpa, as usual, your experience really made it wonderful that you chaired this session. Thank you all. Thank you.
Thank you.
Yeah, so now I invite Dr. Neha Salankar to give vote of thanks.
A very good evening, everyone. Let me begin by thanking the speakers of the evening, Dr. Narasimha and Dr. Preeti, for the very lucid and clinically relevant presentation. And thank you, Shilpa ma'am, for chairing and for your pearls of wisdom. I would also like to thank the president of West Zone, Dr. Sudhir Bhave sir, for marking his attendance. And thank you to Ritambara ma'am and rest of the committee members for putting together such a great talk. And last but not the least, a big thank you to the audience for tuning in, for playing the quiz, and for sticking with us till the end. Everyone, have a good evening. Thank you.
Good
Thank
evening.
you.
I can see Dr. Mishra also here. Thank you, sir, for joining and encouraging us. Dr. Bhave, especially if he's